Welcome, everybody. It's great to be back in person. We've been doing this for, I don't know, maybe about 6 or 7 years, but the last couple of years we've been remote. And also want to welcome those who are joining us remotely to the on-site session of our annual GIS Day celebration. Okay, so the motive behind this is to invite all our students, faculty, and staff that work throughout the Johns Hopkins University and connected communities that work in spatial analysis. Okay, whether it's GIS, spatial statistics, hopefully a combination of the two, and then to highlight their work. And that's what we do here with the poster. So we had an online poster session between 11 and 12, and now we're going to start the on-site poster session. We're very fortunate to have an outside guest speaker with us today. We have a themed table in the back: apples, apple cider, and the world famous apple cider donuts. So there's plenty there, and after our talk, you're more than welcome to help yourself to those. But now let me bring Michael Desjardins up to the mic to introduce our speaker for today.
Thanks, Frank. Yeah, the last time I was here, I was starting my postdoc, so it's going to be back in person as faculty finally. So I'm happy to invite Dr. Valorie Crooks to be our keynote speaker today for GIS Day. She's really a rock star in health geography. And for those of you that don't know, Canada has plenty of universities that do great work in health and medical geography, spatial analysis of public health, and so on. So feel free to reach out to her and us if you want to do some other research outside of the US and just kind of get those outside perspectives as well. So without further ado, I'll introduce Valorie and then we'll start the talk. So Dr. Valorie Crooks is an Associate Dean of Research and graduate in the Faculty of Environment at Simon Fraser University in British Columbia in Canada. I think she said her university is on top of a mountain, so that's very nice. She is based in the Department of Geography, where she holds the Canada Research Chair in Health Services Research. She's the founding editor of the Global Perspectives on Health Geography book series, which is published by Springer, and the lead editor of the Routledge Handbook of Health Geography. And actually, the winners of the poster award sessions will get their choice of one of the Springer books, which is quite nice. And Dr. Crooks also, for her research, primarily uses qualitative methods to explore issues related to health service delivery and receipt, including in transnational context. So a very unique talk today on how we could bring some of these mixed methods ideas into spatial analysis, kind of bridging the gap between both worlds, not only points on a map, but the behavior and kind of attitudes of people that we're studying in health. So without further ado, welcome Dr. Valorie Crooks.
Thank you so much for that introduction. It's very nice to be here. And it's kind of funny that I'm here on GIS Day to give a talk because, as was just mentioned in the introduction, I'm not a GIS researcher. I don't identify as a GIS scientist or a spatial analyst. I'm a primarily qualitative researcher, but I've been involved in a number of mixed method collaborations that have involved GIS over the years. And so I want to draw on that experience and expertise today to talk a little bit about what it's like to actually integrate qualitative research into GIS, because perhaps maybe some of you are thinking about doing that in the room or exploring other kinds of mixed method collaborations. And so this is a talk that maybe will give you some insight into what that is like. Okay. One moment. Here we go. So I am fully aware that not all of you will identify as geographers, but I'm a geographer through and through. My undergraduate degree, my master's degree, and my PhD all in geography. And so one of the lenses through which I see this kind of work, of course, is as a human geographer. And I just wanted to start by actually thinking about why should we as human geographers actually engage with what we consider within the discipline as the third methodological movement. So the first being very quantitative research in human geography, the second being the incorporation of qualitative research, and then the third methodological movement being actually mixed methods research. So sort of what's in it for us? Why should we be doing this? What can it do? What's the value add for the work that we're involved in? So mixing methods, it's argued often allows us to understand more complex research problems. So we can actually ask more complicated questions in the work that we do, because we can draw on multiple methods and often other sources of data that we wouldn't if we were to use one methodological paradigm for our work. So this is one of the benefits of incorporating, for example, qualitative research into GIS. Another benefit is that it allows us to actually use data triangulation, or methodological triangulation. And this is something that we're often looking to do, whether from a qualitative paradigm, we're trying to add rigor into our research, or from a quantitative paradigm, we're trying to incorporate or integrate the validity of the work that we do. So those are sort of the two measures of goodness that we see. One from the qualitative side, one from the quantitative side. So that sort of companion perspective between rigor and validity. And so by actually integrating qualitative and quantitative work, we could enhance actually the outcomes of both of them. And then also we can, as I mentioned already, we can more fully engage with the full range of data that we have access to, as well as the different types and sources of those data. So on the qualitative side, this includes who we might talk to as experts, other kinds of qualitative data, and then integrate them. And so in relation to integration, actually, ultimately what we're seeing in the mixed method paradigm is that it provides us with opportunities for what we would call complementarity. So what does that mean? We're talking about using the strengths of one method to enhance the other or complement the other. And this is where I see there's so much potential for integrating qualitative research into GIS research, bringing the two together for the purpose of complementarity, whereby you actually strengthen the outcomes of both types of analyses, and doing that through this sort of integrative perspective. But I'd say one of the challenges that people face, and I know, Michael and I, we were talking about this exact sort of challenge this morning, is that when people think about mixed method research still to this day, so in 2022, so almost in 2023, we still see people often sort of viewing the qualitative and the GIS, or the qualitative and the quantitative, in almost kind of like a twin tracks kind of perspective. So, I've got this image on the right, you've got sort of two cars passing each other, and dangerous coastline, you're involved in cool kind of analyses, you feel like you're kind of pushing the limits, but you're still reporting them separately. So it's not uncommon for us to actually even talk to somebody who said, yeah, I've been involved in this great mixed method research. You ask them for the publications because you want to learn more about it. And the quantitative and the qualitative are published separately. You actually don't see any form of integration, which meanwhile, what we're looking for is, again, just to kind of draw an analogy, this image on the left-hand side, where it's complex, where we actually see points of intersection, where we see the two coming together. And we need to see the two coming together at multiple points in the research process. And if you don't have that, then you're really not engaged in mixed method research. You're actually engaged in multi-method research, where you're using multiple methods in very distinct ways to address separate or distinct parts of your research problem. I know for myself, I'm often on grant review panels for the Canadian Institutes of Health Research. I couldn't even tell you over the last decade how many conversations I've been in grant review panels where we're really saying, is this really a mixed method study? What is the hallmark that we're going to use? Because if a researcher can't characterize the work they're doing appropriately, they're not going to get the funding. And this is sort of part of what we think of is like, what's the litmus test? How do we know? What are we looking for? So I'm going to provide you in the rest of this talk with a real world example of a mixed method GIS qualitative study. And I'm going to show you those different points of intersection so that you can see and think about maybe how this might apply in GIS applications that you're involved in the future, or maybe even problems that you're looking to address today and thinking about how you might be able to do this. So probably not surprisingly, given that I'm going to talk about a very recent study, I'm going to be talking to you about an example that deals with the COVID-19 pandemic. And again, I want to kind of focus on where we actually draw those intersections and the complementarity. Nothing surprising about these tweets. We're all very familiar with them now, but in early 2020, I think many health researchers, health services researchers like myself, we sort of saw these initial signs. So, this is just a screenshot of these first two tweets from the WHO, sort of putting things on to people's radar. I think that certainly as a citizen, I was thinking, where are we headed with this? And then I think after I sort of gained some recognition of what was going on, then as a researcher, I started to think as well, what is it that I could do? Is there anything that I can use in my sort of expertise wheelhouse in order to sort of bring some new insights around what's happening, and especially in the local context? So in the context of British Columbia, which is the province in which I live and work, which is the work that I'm going to talk about today. And so I guess I started to sort of at a certain point in time think about the pandemic from the perspective of being a health geographer. On the right-hand side, this is a book that I co-edited with a few other colleagues, so Gavin Andrews and Jamie Pierce and Janie Messina, where we actually drew together some of the first health geography insights with regard to the pandemic. But again, at the outset, I was realizing that there was increasing space, especially for social scientists, for health scientists to actually engage, to talk about, to use the unique perspectives that we can offer. And as spatial scientists, for us to use some of the methods that are at our fingertips in order to sort of advance what our understandings were around things such as risk and risky spaces, risky places, around transmission. These are all, as those of us in the room are very familiar with, these are all very spatial phenomenon. And so again, I sort of was taking my cues from what was going on as a researcher. And then I had the one that just kind of like slapped me in the face, because this doesn't happen all the time. And there was a funding call that was put out from a health research funder in the province of British Columbia. And they had specific priorities that they were looking to fund. And one of the priorities is written right there on the top of the screen. And that is, and this is again, where you do not see this every day, a health research funder explicitly saying one of their stated priorities was to look at human geographic considerations in British Columbia with regard to COVID-19, with regard to the pandemic. It could be around a policy focus, it could be around a spatial focus. It certainly is not every day as a health geographer that you wake up and you see a funding call that is explicitly using phrases such as human geographic considerations. It's kind of one of those moments where you say, well, if I can't do it, then who can? As a health geographer who's based in British Columbia. And so myself and a colleague, Nadine Sherman, who's a very well-established GI scientist, we sort of took up this call and said, well, what can we do? What can we offer? Where can we go with this? She and I have a very established collaborative trajectory around using mixed method approaches in order to come up with novel insights with regard to health services, with regard to public health issues. And so really what we were building on was more than a decade of established collaboration in a mixed method paradigm that integrated GIS and qualitative research. So just as an example, we led a study where we were using a vulnerability index to look at where is the best place to enhance palliative care services in rural British Columbia. We did this many years before the pandemic started, but it was a project that I sort of thought we could take some inspiration from, and that we could actually build in a qualitative component into the GIS work that Nadine does, and actually think about neighborhood vulnerability in relation to what was happening at that point in time with regard to our knowledge of COVID-19. And this was, pre-vaccines, this was very early days. And this was when public health officials in particular were trying to struggle with, where should we focus our interventions? What kind of interventions do we need to undertake? What are the communities at risk? Where are they? And this is where we were able to step in and offer some insights using our mixed method approach, drawing on work that we had done together for over a decade that made us both very comfortable. For myself with the GIS side that she brings in, and for her with the qualitative side that I bring in. So the goal of our collaboration through this funded project that I led was to produce a series of maps. And this is the goal that we stated at the start. Of course, as the pandemic evolved, our own thinking evolved, which I'm sure is not surprising to people in the room. And I'm guessing that many of you were probably involved in projects that evolved very significantly as our knowledge of COVID-19 really emerged. But what we wanted to do was create a series of maps that really identified specific locations in the Canadian province of British Columbia that were potentially going to be at risk of experiencing higher rates of COVID-19 infection. So again, trying to be able to speak geographically to public health officials and give them the kind of tools that they would need based on our years of collaboration together. We also, at the time, were thinking about doing another model looking at inadequate spatiotemporal access to ICU care, which is one that we ultimately didn't pursue. And then we did also pursue this final one around being vulnerable to the secondary effects of the pandemic, and how that can actually be used to support informed decision-making. I'm not going to talk about that model, but if anybody has any interest, let me know and I can share with you the story map that we ultimately created. So, thinking about the sort of public health tie-ins in relation to this work, one of the things that I thought I would mention that was really interesting and unusual was that in order for us to obtain the funding for this work, the funding agency actually organized for us a few meetings with people in the Ministry of Health, where we actually had to talk to the applied decision makers about what it was that we could do. And they needed to indicate that this is something that we want. That's a very unusual step in terms of obtaining health research funding, but it was not going to be funded until we had that process that we went through, which for our project went through just fine. There was a lot of interest in what it was that we could do. So that was our sort of first point of contact with the public health community, the health policy community, and the ideas that we were coming up with. And I'll mention throughout the rest of the rest of this presentation, the other sort of points of contact that we had with the public health community. So, the objectives really that we were working with were that we wanted to create a decision support tool. We wanted to create some form of map or maybe an interactive map that would be actually useful for those in the public health context who were having to make very rapid decisions about rolling out public health interventions very early on in the pandemic with incredibly little information about what these interventions should be, but also where they should be focused. Many of us who are involved in health research or health services research will know that one of the biggest constraints that are faced with regard to public health interventions are funding. You only are going to have X amount of dollars and you need to spend them as wisely as you can. And one of the things that we can do as spatial scientists, as GIS researchers, are actually tell people where those interventions should be located, because it helps to actually assist them with making those decisions around where the money should be spent, not just for the intervention, but geographically where it should go. So we called the models that we were building the Corvix models. So we actually wanted to refine the Corvix models as new information was coming to us. And then we also wanted to obtain feedback from end users about how these models could be improved. And this is where actually the second and third bullet points are where we decided to sort of create this qualitative component. So I'll tell you about what we did for that, how we did it, and actually how we integrated it with the GIS so that we were actually refining the models based on the feedback as an aspect of the project work that we were undertaking. So I'll talk to you now for the rest of the presentation about this first model that we built. So this is a model that's looking at neighborhood vulnerability in relation to COVID-19 exposure and transmission that was applied in British Columbia, Canada. Well, we ran it, but we had extensive conversations with people across public health units across Canada, outside of Canada, who wanted to adapt it, uptake it into their communities as well. So how did we create our vulnerability model? This was the process that we used. So first, we needed to identify variables that actually tell us something about risk. So the risk of exposure, the risk of uptake. We then, of course, needed to make sure that there were data that we could link to these risk factors. So if we actually had no ability to link a risk factor into the model using data, then it ended up being a factor that we didn't integrate because we wanted to produce maps as an outcome. So in Canada, we heavily use kind of census data for GIS research. And so that is what we were using primarily, although there were a few other sources of data that we had. So then we needed to sort of integrate the variable in the model. And then the fourth step is the qualitative component, where we sought feedback on the model from key informants. So we actually undertook key informant interviews, and I'll tell you a little bit about those in a few moments. And then based on the outcome of those interviews, and also what we could do with the model, we actually refined the model to create maps and share them widely. And it's this fourth step that shows that integration. So we were not running these parallel streams of a qualitative project and a GIS project. They came together and we refined one based on what we learned from the other, and then move forward based on the insights from both the qualitative interviews, the key informant interviews, as well as the model that we had created. So where we started, I think, like many people who were trying to do any sort of applied research at the outset of the pandemic, we were looking at the literature, we were looking at what was emerging. We came up with this list, very long list of variables that we might want to incorporate into the vulnerability model. This came out of the literature. You can, if you think about the temporality of the pandemic, I mean, you can see where this is coming from, where there was a lot of discussion around smokers, for example, and their vulnerability. Also in British Columbia, we often have extensive wildfires, and so air quality became a huge issue. So all of the things that were really discussed in the popular literature, because again, there really wasn't much scientific literature at the time, these are variables that we very much talked through in terms of, could they be incorporated? Should they be incorporated? What does it look like to incorporate them? We had a team that was led by myself and Nadine Sherman. We had graduate trainees on the team, and we also had a patient partner on the team. So a community member who joined us in every step of this project, who was there giving their insights, offering new perspectives, who actually was based in the interior part of the province. It was very useful to hear from somebody who actually was based in a different part of the province, have them sort of talk through these variables and how they understood them. And then we sort of had this critical moment, lots of these kind of critical moments, I think, for many people that were undertaking COVID-19 research as the pandemic was unfolding, where we realized that we actually had to think about vulnerability in two very different ways. And that we were actually capturing it in two ways, and we needed to integrate them both into the model. And that is that this sort of light bulb moment for us was, we realized that we were looking at factors that dealt with the infection risk as well as the exposure risk. And we needed to actually bring these both together to integrate them and look at overall neighborhood vulnerability, which was what we were ultimately trying to find. So in terms of creating the model, ultimately, the indicators that we felt looked at that sort of relative infection risk. So creating the index that we use for that, you can see this list here. So things from living in a large house to not knowing English to being a public transit user and others in between. This is one of the first sort of map outputs that we had created once we had run the model, and all of the variables, just so you know, we had weighted them all equally because we had no rationale for weighting them other than equally, because evidence was very new at the time in relation to the pandemic. So this would be sort of an example of one of the variables. So here we've got the public transit users, where it was possible to sort of look at each in relation to a layer, as you would know. But then when we brought it together, so just to kind of help you spatially orient, on the top left, that's the entirety of the province of British Columbia in the lighter gray shading. And then the larger sort of inset that you can see, this is highlighting what we call the sort of greater Vancouver area. So this is the most highly populated part of the province. And you can see, again, this sort of relative risk for infection by neighborhood based on the factors that we had integrated into the model. And then there's the issues around relative exposure. And this has a lot to do with, as we know now, where do you go? Where do you work? What are the kinds of places that you're going to be in that might expose you to potentially ultimately contracting COVID-19? And so we needed to kind of bring this together with that relative risk aspect of the model. So these, again, are the ones where the evidence was emerging. So we ultimately had 12 factors that we included. So of course, each one we can look at within its own separate layer. as you see here, but then of course, bring them together and see what they look like. And then ultimately put together our vulnerability model. So this is what we were looking to produce. This static map would be an example of one of the earliest outputs that we had from creating the vulnerability index. So then our next step was actually to conduct interviews with people who would have some sort of applied knowledge in relation to this issue of risk and vulnerability, and or would potentially be a high level policy user of this information. So this is what we would call a key informant interview. So we were looking to talk to people in a professional capacity about their professional experience. And often one of the benefits of doing key informant interviews as a qualitative researcher is that although you may potentially interview a small number of people, they're talking across their professional knowledge, and oftentimes will be sharing experience that even reflects sometimes tens, maybe even hundreds of people that they've been interacting with, their colleagues, et cetera. So in the interviews that we conducted, we really wanted to get in feedback from people around the index in terms of, are there any factors within the index that they think are not appropriate, any changes that we should make, but also how would they want to use something like this? So at the time of the interviews, we actually just had these static maps. We did the interviews on Zoom and we screen shared them to talk to them about what it was that we were coming up with. And so what did we hear from the interviews? So we ultimately did 15 key informant interviews, again, with people who are very specifically selected, who had high level expertise to be able to offer that would help us either confirm or refine the model, as well as give us insight into how it might be used. And so what we heard from the interview participants was that we need to have an interactive map or website. Of course, this makes sense. It's not something we were opposed to, but we really wanted to hear it from this community. So ultimately, we created story maps in order to release this information. Also, what we learned from participants is that their insights helped us understand what guidance we have to give to people so that they can interpret the maps properly. Because we had to know from these interviews, what did we have to tell them so that they were understanding the maps and that they would actually use them in the appropriate way. And if you have to tell the information to high-level experts in public health, then you know that other users are going to actually even have higher informational needs. Also, these interviews really helped to shape our thinking about what we were actually trying to show and why, because of course we got a lot of questions of like, how would I use this? Well, what's the purpose of this? What is this going to tell me? And then finally, we did actually make some refinements to the variables that we incorporated. So again, this is showing that integration of the qualitative and the GIS, because after we got these insights from the key informant participants, then we went back to the model and made refinements and made changes to the model that we ultimately released publicly. So in terms of that sort of guidance on interpretation that we really gleaned from the interviews in terms of what information do we have to give people so they know how to uptake this information. And I think as well, this is something that we don't often think about in relation to maybe, specializing in GIS or spatial statistics, is that we can lose sight of what do we have to tell public health officials so they know how to use this work. So, the standard one, all models have limitations. And so we really emphasize that you need to use this in combination with other sources. It's not supposed to be the be all and end all in terms of our story maps. There are limits to the data that we could use and, standard kinds of things that I think in the research community we know, but when people are in an applied public health or health policy context, they can lose sight of these factors. And that one of the very important things that we wanted to emphasize is that the models that we produce, they really should not be used to attribute blame for transmission to specific people, because this is in part what some members of the public and some people were looking to do, is being like, oh, this is a high-risk community, and we know that this community or this neighborhood or this census tract is filled with many people in maybe X socio-demographic. And so this is showing that these people are transmitting, and that's not at all where this model would provide any evidence. And the final thing that I think was very important for us to communicate is that our models used a business as usual approach. So we did not take into account the public health measures. So we weren't adding as a layer, for example, where COVID-19 cases were emerging. And we did that intentionally because in many ways, we see these models as showing us where public health measures may have actually been successful. So if we see communities that come out as high risk here, and then we actually know that the number of cases were quite low, then what we're probably actually seeing are places where public health measures were effective. And that is a really important insight for us to have coming out of the pandemic. So as an example, this is sort of the list of variables that we ultimately sort of included in terms of that sort of personal risk. And then place-based risk. So, you know, that aha moment where we realized that we were actually looking at two different kinds. And then ultimately this model that we created. And if anybody's interested in seeing the story map, I'm happy to share it. And then just briefly, before concluding, I wanted to mention this final interaction or intersection that we had with the public health community. What we did, because we kind of thought, well, how do we get this work out there? We released a press release when these maps were available. It was, I remember very specifically, it was December 24th, because then this is how I spent my holiday period that year. It was actually the lead story on the 6 p.m. news in terms of this neighborhood vulnerability work. It's not something that many of us have the opportunity to have the 6 p.m. lead story on the news, but that was what was going on in terms of people's level of interest. During that holiday, this was a real life illustration of my inbox. And it was very fascinating to actually see all of the different potential users who were actually reaching out. So again, had uptake from people in many different public health offices in particular, from across the country as well as elsewhere, that were inquiring, how did you do this? What can we do? How does this work? As I mentioned, we also did run the second model and create it in terms of looking at the secondary health impacts. If this is a model that you're interested in, chat with me during the poster session. Happy to talk to you about it. And then, of course, that map itself also, or that model itself also got a lot of uptake. But before I conclude, I just want to emphasize that, you know, the mixing of these methods created a project that could never have had the level of impact it did if it was a GIS project alone or solely a qualitative project. It really was amplifying the power of both of those methods, using that triangulated perspective and bringing the two together that actually brought this level of impact and this level of visibility in the public health and health policy communities. So with that, I'd really like to thank you for your time today. I think there's maybe some time for questions.
Yeah, probably have 5-10 minutes. So if anyone wants to start. And if there's anyone on Zoom that wants to ask a question, feel free to post it in chat, and we'll make sure to try to answer that.
Yeah.
Just to hear more about the process of identifying those key components, like what sorts of things you're looking for.
Yep. Yep. Sure. So just for people on Zoom, the question was just around identification of the key informants and how did we do that in order to sort of basically consult with that group. So there were a number of strategies that we employed. First off, we actually looked at public facing, not just the names of people who were doing a lot of media interviews, but specifically their roles in expertise. We also looked at things such as organizational infrastructure kind of maps and outlines of people who were working in what in British Columbia we call health authorities, so the regional kind of decision-making bodies with regard to health services. And then also, we also sort of had the opportunity from the outset to sort of have that policy interaction when we received the funding. And so that also attuned us. And then as we were conducting the interviews, we did also ask people that we were speaking with about areas of expertise or professional experience that they're aware of that people would be drawing upon this work. So we weren't asking them necessarily to connect us to specific potential participants. That would be kind of snowball sampling and doesn't really fall along kind of many ethics board approvals, but we really kind of kept it at that expertise level and then use organizational maps to help us. Yeah.
First, applaud you for bringing this to us. I mean, it's a great opportunity to mix qualitative with quantitative in terms of spatial analysis. I come from the quantitative side.
Yep.
Okay, and when we build models, we know how to evaluate their performance.
Yep.
whether it's space or time, and so forth. And my original question is going to be, well, how do we evaluate it in a qualitative sense?
Mhm.
I think you got to some of that with the key informant interview.
Yeah.
Okay, that was focused more on how would you use it.
Yes.
how to interpret it. But is there a thought, and this may sound stupid, but is there a thought to say, how well does the model fit qualitative?
Yes, in terms of the ultimate use of it, for example, or
In terms of whatever qualitative person would think is important in terms of the model fit.
yeah, I think that, so yeah, the question is in terms of, from a qualitative perspective, how would we potentially evaluate the model? And, one of the things that was very hard for us to kind of come to peace with in doing this work was that, we did not include an evaluation component or look at the uptake of the model because things were moving so quickly at the time that we felt that we weren't able to sort of most effectively do that. But I would say from a qualitative perspective, if I were to look at how does this model fit qualitatively, I would probably use something called a utilization focused evaluation, where I would have the opportunity to go back and actually talk to people within the public health community and health services communities, not just about the fit of the model, but also the uptake of it and how does it fit with what they need in their work environment. Because I think that's one of the most important things that many of us in the research community need to learn from the pandemic was not, I mean, as researchers, we can come up with creative kinds of analyses all the time, but we need to know which ones were the most valuable, which ones were the most usable, and also what were the contexts in which that value met use and actually produced something that was of importance for the decision-making community.
Yeah, no, I agree. It
Yeah.
should stop with publication.
Yeah, yeah.
Talk about like the actual COVID-19 transmission data.
Yep.
Seems like a good opportunity to utilize a bivariate method to see kind of the high risk areas, like the high risk COVID cases.
Mhm. Yeah, and that would actually be a very great qualitative or another actually mixed method project, because it would be a great opportunity to look at places where there was alignment and also misalignment, and then drill down probably qualitatively to understand if some of that misalignment, so communities identified as at high risk of vulnerability from our models, actually had low rates of transmission or low rates of infection. And then if we can see if that has any connection to the public health measures that were put in place, because this work, again, we did not consider things like the closure of bars, the closure of gyms. And we know that there were varying degrees with which particular kinds of communities were applying those measures in terms of their kind of strictness of them. And so it would be very useful to actually do that and go back with another mixed method perspective. Yep. Yep.
Is there a particular qualitative methodology that is used in these types of GIS methods studies or like
Right. Yeah. Yeah, that's a great question. So the question was if there's sort of a typical qualitative methodology that's used. And so I've certainly seen, I'd say, two methodologies that I've seen probably used the most in relation to mixed methods between GIS and qualitative would come under the methodological rubrics of sometimes I'll see that in relation to ethnographic work. And then the other sort of traditional qualitative methodology of those traditional big seven would be case study. And so this would fall under the methodological framework from the qualitative side of case study. Yeah, in terms of like very much focusing on context and context driven. This is not to say that other qualitative methodologies could not be used and integrated into GIS research in a way that would provide meaningful outcomes. Yeah.
For the variables that you were looking at, all the different risk factors, you said at the beginning, limited evidence.
Yeah.
They were kind
Yeah.
of after after you had the key informant used the refinement process, is there any like reweighting or?
No, so in fact, so the question is, after we did the key informant interviews, did we weight the variables differently, even though we had weighted them equally going into the first days of the model? Just restating this so people on Zoom know what the question was. And so actually the interviews really confirmed that even people on the ground couldn't provide us with any justification or rationale for us to weight them differently. So here, I'm not providing you with direct quotes from interviews or like a high level analysis, but if you saw our interview guide, that was something that we were talking about with people was, is there something that strikes you as being more important than others? And we couldn't kind of reach any consensus in the decision. And also, the participants couldn't provide us with the rationale we would need. And then on top of that, evidence really wasn't there for us to incorporate it. It's probably one of those things that 10 years down the road, we'll be able to look back at a project like this. And with our knowledge at the time in the future, we'll be able to say, this is how we could actually incorporate weighting. Yeah. And just to clarify, in other work that I've done, other mixed method work that I've done with Nadine, I know I put the slide up around the rural palliative. These were things that we were actually assessing through the interviews, because of course the research that we were doing was much different and not with a topic that was evolving as we were working on it. And so in that model, we did do weighting. And one of the things that we were able to do through the qualitative interviews was to help us to actually determine how that weighting would look. Yeah. I can't see anything.
I think we have one question.
Oh, yes. Sorry. Okay, so the question on Zoom is, how was the accuracy of the new index? Does this could it accurately predict risk to COVID-19 exposure and outcome? I'd say, again, this is the kind of thing where we need to be many years in the future and looking back in order for us to sort of assess things like accuracy of this type of model. The other point that I would make, that I had many conversations with people in the public health and health policy communities, is that it's actually very difficult to assess the accuracy of this model, in that, again, if there's a mismatch between what happens in terms of COVID-19 outcomes and where we would see risk and concern in relation to this model, most of it is pointing us towards where we're seeing success of public health interventions. And so this is where it becomes very difficult to assess accuracy, for example, in relation to the not business as usual model that would actually integrate those public health measures into it. And so that's something where if we did the kind of research that Michael was suggesting as the next step, where we actually then looked at cases, and then we had a qualitative component where we drilled down and talked about success of public health measures, if we out of that still saw a mismatch, then we would probably start to question the accuracy of the model. But this is also one of the things where in that guidance that we include on the story map, we make it very clear that it's not to be looked at as a sole decision support tool. It is intended to be looked at with a fulsome kind of availability of the information that you have at your fingertips in order to make a decision. And we all know as researchers, as scientists, that probably none of them will be 100% accurate, which is why we want to advise people to look at multiple sources. So thanks for that question. Yes.
I think you said the interviews were just with screenshots of the maps.
Yes.
Not interactive.
No.
Drive that. Were there any results or census tracks that the informants or the interviewees responded to that helped change the map? Like, well, why is this census tract that?
Right.
Gaining?
Not from the interview participants, but when these maps became publicly available, because they were carried, in the news immediately with links, and based on, again, that burning email inbox image that I showed you, we were actually tweaking and refining the maps and that interpretive information that we gave based on some of the feedback that we were getting. And the most common question that I got, and I got it enough times that it became, I don't know if I can, the most common question that I got was about, sorry, the Zoom screen is up here. Let me just close it. this area right here, oh, sorry, it's not showing you with the mouse. So if you look at the Vancouver map, you can see kind of like a bright purple, like sticking up in the middle of the white water. I'm not sure if anybody is familiar with Vancouver, but if you are, this is a census tract where Stanley Park is located, the biggest urban park. And I had the number of people that emailed me that were like, why is Stanley Park showing any risk? What is going on? And it was very fascinating, actually. It was a really wonderful conversation with members of the public. And I was explaining that it's probably hard to reconcile, but actually that area includes a number of high density condos that are on the edge of the park. On top of that, the park offers a number of services and amenities. There's sit down restaurants in the park. There are sports facilities that ultimately became closed. And so although when you look at that, because it's very distinguishable in the Lower Mainland, if you know it, you're thinking it's all trees and like, how would this be high risk? Once I explained that to people, they seemed quite satisfied, but it was very interesting to see the consistency with which I was being asked about that one specific part of the map that we were looking at. So didn't get that level of granularity from participants, but got it from the public, because of course, the very first thing people want to do is go, let me find my neighborhood. And that's why we included that interpretive information that said, this is not intended to show any causal connection. And I did a lot of media interviews, and I had a reporter asked me at some point, so, for example, like, should we determine where we walk our dogs based on what we see here? And I was like, I'm glad you asked. The answer is no. And I explained, but that's exactly it. You want to go beep, boop, boop, enter it, my neighborhood, my this, my that, zoom in. What do I see? Oh, I know that's Stanley Park. This is where I go. This is it. So yeah, thanks for your question.
Yeah, thanks everyone for your questions and another round of applause.
Thank you.